Hello and welcome. This is a presentation on management strategies for clinical nursing faculty. I hope to share with you practical tips and pearls for teaching when you have a clinical group of nursing students of 8 to 10 or upwards students that you're taking onto a hospital unit. This is meant for both brand new clinical faculty and for faculty looking for different ways to manage the entire clinical day. My name is Sarah Craig, and I've been a clinical faculty since 2011. I have had clinical groups of both advanced practice nurses, but more often than not, pre-licensure students from multiple tracks of entry, our RN ADN students, RN to BSN, our traditional BSN, our accelerated BSN, and our MSN entry into practice students that I've worked with across the state where I practice. And over the years, like many other new clinical faculty, I didn't really have an orientation or any training to become a clinical faculty, and so I kind of had to learn as I went. I used lots of evidence-based resources to improve my knowledge. I also tried to take some of the elements from some of my best clinical experiences as a nursing student and apply those, but I often found that I needed a lot of dynamic flexibility. I also needed a mind shift change as I went from clinician expert to novice clinical faculty. And, really and truly your students become your focus and almost your patients as you will. And so in many instances, although you are doing a lot of the care for each of the patients that your students are assigned to for the day, you have to remember that you need to convey to the unit staff you're not assuming all care of the patients. You really are helping facilitate a learning environment for your student nurses, maintain patient safety, but making sure that it's really clear from the onset what your role is there for the day, especially if you work on that unit. Being really clear of what days you're teaching on the unit and how you have to manage your time during that particular day that you're there with students. Really and truly, that oversight of that clinical group of students is so critical, and you can't manage multiple hats while you're there in that role for the day. So really kind of trying to not only in this presentation talk a lot about preparing your unit and your students and setting expectations, but also thinking about how you prepare yourself and what that mindset shift looks like moving into the faculty role. So setting expectations is critical when you are working with a group of learners, especially learners that are newer to the profession and newer in their clinical training career. So first of all, you have to know the course that you're teaching in. So orienting yourself to the syllabus, any paperwork that you're going to be asking the students to complete, the grading and the grading rubric of that paperwork, calendars, when does the semester start? When does the semester end? Are there any academic holidays that you will not go to clinical? What do you do if there is a day where there's weather? What specific academic policy and guideline do you follow under those circumstances? And then are there other key dates? When are your midterm and final evaluations? When is your grading due each week? When is your grading and grades due for the entire semester? Other things are, who's your primary point of contact for the particular school of nursing that you're teaching with? Do you have an assigned mentor, or do you need to find an informal mentor to really help be able to ask questions of? A lot of schools have a course professor and a clinical coordinator who is a support person for you that you can always troubleshoot with, check in with, ask questions of at any time during the week. Next is creating a welcome letter for your students. So I'm going to show you an example, but you really want to talk about the type of unit they're going to be coming to, where to meet you that first day, what they should bring, what types of activities they're going to be doing the first day, what type of teacher you are, what's your quick teaching philosophy, what your professional expectations are. It is really critical from the welcome letter before you even meet them to be really clear about what your expectations of the group are when they're in clinical training. This might be simple things like cell phones are only for looking up information if that's allowed on the unit, or cell phones are meant to be kept in with your personal belongings throughout the shift, except for when you're on breaks. And so this is a time to be really clear. Other things of what does it mean to be late? How do you communicate if you have something come up and you're not going to be there on time? Or maybe your paperwork's not going to be in on time. Setting up those clear lines of communication of how they can reach you. Other things are setting up a group chat. Some people use a group chat or group text on their cell phone to convey quick information. Let's say for some reason you need to change the plan and it's the night before clinical. That's a really great way to make sure you get the information out quickly, versus email is great too, but not everybody is going to check that, the night before and the morning of clinical because they're trying to travel there. So let's look at a quick welcome letter. So this is an example of a clinical letter that I send to my clinical group, just a variation on that. So I am welcoming them back because I also want them to know that I'm approachable. I try to create an inclusive learning environment, and I really want to meet students where they are and help them grow and meet the course expectations as well as their personal expectations. And so I really feel like it's psychologically safe to set expectations, but start to create that environment of approachability as well from the beginning. If you are kind of relaxed and not super clear at the beginning of a rotation, that can send very mixed messages to that particular group, and it's really hard to go back and repair and set expectations several weeks into the semester. I'm really clear about where we're doing clinical, what our rotation is, what day is our first day, what time, where we will meet. In this particular case, we had some skills refresher and review first before we went over to our hospital unit. That was really important, and gave me a chance, even though it's for them to refresh and practice skills that maybe they have not done in a long time. It was also a really important time always, every time I start a new rotation, to assess them, both with their critical thinking and clinical judgment, and also their psychomotor skills, and then and getting to know them better. What's their kind of affective domain? What's their thinking? How are they feeling about the nursing profession, about the clinical rotation? It gives me a starting place, and it does help me plan and make assignments. Also making sure all of their compliance is done, they have their access done, anything that's been assigned by their school. Something else that I do is because my unit is a high acuity ICU, I have prep work that I have them do with common meds, common diagnoses, and complex ICU procedures that I expect them to have reviewed ahead of time. I also get them to create a Google Doc so that they are assigning this work and creating a shared document that they can review as a preparation document from week to week. And then that allows me, as I send out kind of the plan for the week going forward, I can say, we are going to be able to have the opportunity to take some care of someone with an arterial line today or a chest tube today. I'd really like to make sure that you go back and review that information that you gathered during week 1. And then kind of, again, trying to make myself come across as approachable, because it is a very high stakes, high stress situation, no matter where you're doing clinical. In some ways, I feel like it's easier in the ICU because they are kind of recognizing it's a high stakes area, and that's true of any specialty, but it's really true of any rotation they go to. They're new, they're unsure, it takes them time to acclimate, and so making sure that I'm addressing their concerns and anxiety week 1, and that we're working through things and setting micro goals makes a huge difference. And then letting them know the best way to get in touch with me, and also please don't text me after 9 p.m. or before 4:30 a.m. I also want to make sure that I'm really, really clear about my communication. They can text me any other time, but not after 9 p.m., not before 4:30 a.m. Getting text messages and phone calls at 12 o'clock a.m. because they're not feeling well is not appropriate, and just trying to set that expectation again from the beginning. So the welcome letter usually goes out about a week before our clinical rotation starts. Sometimes if I give them a lot of preparation work, I'll send it out even sooner than that. And I usually give them 2 weeks to get that, ICU readiness document done. That's kind of helping them get to know their unit, feel more confident in their unit. And then I also spend time on the clinical unit that I'm going to be teaching on. If it's somewhere that I've worked before, it makes it very easy to go in, kind of talk to people at huddle and at the kind of unit shared governance meeting, and kind of let them know that this is the group of student learners, this is the level that they are, this is going to be our objectives while we're there, this is how to get in touch with me, these are the expectations I have of the unit. It's also a great time to get what are the expectations that you all have of us as guests on the unit. And I would say if it's a unit that I have never taught clinical on or worked on before, I spend even more time on that, what do you expect of us as guests on your unit? I also spend time learning the routines of the unit, the particular patient population, common meds, common skills, to make sure I'm as prepared as possible to facilitate learning while I'm there. I also try to do some community building and get to know everyone while I'm there, to make sure that I'm not overburdening the unit as well. I want to make the best assignments for everybody when we're up there on the units. And, it takes several reminders of that preparation of the clinical unit. I can't just send an email and introduce myself and say, hey, we're coming next Tuesday. I really do need to do some more intentional preparation to make sure that we're going into a complex, dynamic clinical situation where patient care is being delivered. How do we transition into that and very quickly become part of the team, able to learn a lot, but also to help the unit out while we're there as well. And so I can't overestimate how important that preparing the clinical unit is, especially if it's not somewhere that you've worked before or taught clinical before. Continuing to be able to translate the syllabus and clinical performance expectations to learners is really critical. What does it mean to be professional? Being clear about that with examples of, what does it mean to be on time? It means that, you've taken care of all of your own personal AM care, you've eaten breakfast, you've arrived, you've stored your belongings, and you're ready to go at the time that your clinical starts. And so do not underestimate that people will know that coming into this, even if they are not a beginner learner, because they may have had different expectations in a previous rotation. And so I think just kind of starting from that point, being very clear about every aspect of clinical performance. And then other things are, what's the expectation for supervision? What do you need them to come and, get you and communicate with you versus what can they do autonomously or independently? Now, finding that information out, a lot of that should come from your school and your particular course that you're working with, of what skills can they do independently, what needs supervision, always. When do you have to supervise versus a staff member on the unit? Your facility or healthcare system and unit may also have some specifications as well. And so making sure that you're able to translate that information and then hold students accountable to that is really important. It also helps to continue to check in on, are we making progress towards the goals of the semester? Clinical day one is so critical for setting these expectations and also building a community of your clinical group. Making time for everyone to get to know each other. You'd be surprised how many nursing students don't know each other and have never worked together, and are not always able to form a team quickly and work cohesively. Another part of that is working on a collaborative environment instead of a competition environment. And so really trying to reinforce, what does it mean to be a high-performing team? I think that's something that our student learners need coaching and guidance on. And again, the skills, if you can get in there day one or during the first couple of weeks, it really does give you a chance to assess your students in a low-risk environment. If you can't get into a skills lab, I also will use the conference room or an empty room on the unit to do just some brief check-offs so that I know what I can, where students are. So for example, sub-Q injections and needle safety. When I'm on the unit, I always will roll up a towel, get some injection equipment, pretend to give a sub-Q insulin or heparin injection, and just make sure that my students are safe in their practice and they don't need additional attempts in practice before we go and do that skill and medication administration on a real patient. We talk a lot about what are our resources to look the medication up, the psychomotor skill itself, and then all of the kind of clinical judgment and critical thinking around giving that common medication. And some of that is being, learning through extensive time in the clinical environment, that if I do that ahead of time with each student and find time to do that each week, it just makes things go much more smoothly in front of the patient. A lot less safety issues if I take the time to do that and then reinforce throughout the semester. So let's talk about making clinical assignments. So in making clinical assignments, I communicate each week to my students what the plan is. I do prefer the group chat. I do also send an email as well if I've got a lot of information to convey, especially in those early weeks. Sometimes my group chat text will say, please check your email. I have some important information to share about tomorrow's clinical. I share the general plan, any updates about the unit, like maybe, it flooded over the weekend and we have 10 rooms closed, something like that, just to kind of give them an update on what's going on, how that might change the environment of the unit for the day and staff, and what the preparation expectations are. So maybe I went to the unit, or I've been working on the unit all week and I know that we have several transplant patients. I will let my students know, you must review your transplant meds and you must review heart and lung transplant. And that just allows them to come in, not be blindsided by a very complex patient, for example. I also have a very kind of detailed daily checklist. A lot of students have performance anxiety, and the more they can kind of review what's expected of them during the day, the better. So, you have your course expectations and objectives, you have the clinical objectives, and then, how does that work out and operationalize on your specific unit? And so by sending those expectations ahead of time, and it's just kind of the same thing that I would give to anyone new coming to practice on the unit. So when you arrive, look at what your assignment's going to be, go ahead and print your rhythm strip, go to huddle. That could be with your course faculty or directly with your nurse, again, depending on the level of the student. And then huddling with the instructor to make sure that you're clear on expectations and plan and care delivery for the day. And so just a checklist of things that really kind of keeps them on track with what they should be doing, because a lot of learners will wait for you to come and tell them, again, especially if they are newer in their practice and in their clinical training. So this gives them some guidance while you're trying to see each of your 8 to 10 students. What are their daily charting goals? Again, this is an area of electronic charting that I find is inconsistent in students and their previous experiences that they come with. And so making really clear that by 10 a.m., I need to make sure that your physical assessment is complete so that I can review that, during lunch. And then other things that they should review in the electronic health record. So that just gives some tips and guidance to help them stay on task. So that, again, they're not waiting on you before they go to the next thing that they can be doing to enhance their learning and their care delivery for the day. It really helps, too, so that when you have your huddle time with each student, that it's productive and efficient, and you can be focused on clinical questioning and coaching, critical thinking, and assessing their clinical judgment, ability to start, making guided decisions about nursing care. So how do I make my assignments for the day? That is a really important aspect of the day, to come up with a game plan. So I try to arrive 30 minutes to an hour before the clinical starts. If it's a unit that I'm very familiar with and I've worked that week, I can very quickly make assignments. If it's a unit I'm not familiar with, or it's a unit that I haven't been on in a while, I may come in the day before and get a general game plan just to decrease my anxiety. Or I can look at Epic remotely, our electronic health record. I know other colleagues that will actually call the unit charge nurse at night and get kind of a quick report so that they know what they're walking into in the morning and can kind of have a general plan. So some of that is as much to make sure you're organized for the morning, but also to decrease your anxiety and stress level starting the day. Some really key things are to always check in with the charge nurse or shift leader. Ask them, what would be a great learning experience for the day? And then, are there any staff members that need a break from teaching and having students and trainees? Is there anyone that's precepting? Are there any patients or patient situations that we should avoid for the day, so that we don't escalate someone that's already in a stressful situation? And that's from a student safety perspective, and also just, again, unit and staff burden perspective, and also for the patients, if there's a patient that's refused a student in the past. I can't say enough how important it is to make realistic assignments. You want to both consider the level of the learner. What are you really trying to accomplish for this particular course? So think about, is it a fundamentals course versus a specialty course versus they're getting ready to graduate course and they need as much experience as possible. Another thing to consider is what's the census and acuity level of the particular unit that you're teaching on. What's the staffing level? What types of patients do you have on that particular given week? You want to make realistic assignments with your med pass in mind. Be very mindful that it can take up to 45 minutes to give meds with one student, depending on how often they've given medications and how much training they've had prior to starting the clinical. So my rule is that I give less complex patient assignments to the students that are going to be giving meds in the morning. The morning med pass is usually your heaviest. And so with that in mind, I'll give the more simple medication administration list and patients to the patients that are giving morning meds. I'll give the more complex patients with more complex meds to the students that are not giving morning meds. I try to give meds with 3 to 4 students in the morning, especially when it is taking that long, because I don't want anybody's meds to be late. And then for the students who weren't giving morning meds, I'll try to do, and this takes a lot of communication with the primary nurse, I'll try to do lunchtime insulin or afternoon heparin or Lovenox, again, depending on what type of unit you're on. Or, I may do afternoon before we leave antibiotic or some other type of medication that I can do. So when I make assignments, I do spend quite a bit of time looking at their med list just to make sure I have a good balance of what I'm able to realistically accomplish in the morning. And then how I can make sure that my other students are getting some opportunities to do some medication, critical thinking, judgment, and skill as well. And that really helps balance out. I also try to reserve my after lunch time to get other types of skills and interventions in as well. This clinical is all about getting them to think like a nurse, to acclimate to being a nurse. But I also find that if I can get them to do a lot of tasks and medications in those first couple of weeks and learn unit routines, it builds their confidence a lot more so that they can really concentrate and see the bigger picture and start to really truly critically think. If they can't go in and use the Dynamap and get a temperature, they can't focus on anything else. They can't see the bigger picture. So I try to do a lot of deliberate practice in the first couple of weeks, and really try to help push and grow the students from there. It also allows me to make referrals early for students who may need a little bit more coaching and support that's often provided by the schools of nursing. Something else that I do as I'm making assignments, I'll actually write a micro goal beside my assignment on my assignment sheet. So I may say, central line dressing change rounds happen at 9 a.m. Be there, be able to assist, observe, do the dressing change, depending on the situation and the staff member that's there. Other micro goals might be talking to this patient about their type 2 diabetes, or doing intake and output on someone with multiple surgical drains. So those micro goals can be really helpful for your students to help them feel like they've accomplished something. And it also, again, you're going to spend more time with your students that you're giving meds with that in the morning. And so if you have some micro goals for your students that aren't giving meds that morning, it does make things a lot more clear, and so they stay directed in their learning for the day and engaged. So I'm going to show two separate organization sheets that help me with making assignments. This one is required of the particular health system that I work with, and you have to include the student. I often assign by nurse rather than putting the patient information on this sheet, but some hospitals require you to put what patient specifically the student's working with. So I'll often put that as well on the one that I put at the charge nurse desk and the secretary's desk so that they can clearly see who's working with particular patients. Primary diagnosis, any special responsibilities that are expected of the students, in addition to the ones that are listed more generally. And I make changes to this as the day goes on as well. I definitely do my first one of the day in pencil so that I can erase things before sharing it out. Once I have this assignment made, and I give one to the charge nurse, one to the secretary, and then if I have a student charge nurse, they get a copy of this as well so that we all have the same information for the day. This is my larger kind of plan for the semester. This tells me who my students are, what week of the semester that we're in, when midterm and finals are, if we have any simulation days. It also tells me when they are going to be team leader or charge nurse for the day. And then once I've assessed my students week 1, I then will assign who is giving medications consistently on the weeks after that in the morning versus the afternoon. In the morning, the first couple of weeks with my faster students that are more skillful, because then it gives me more time to spend in the afternoon with my students that need a little bit of extra coaching and guidance. This is something else that I might make this for the whole semester, but then I might change something. And I'm just really clear about why if I do change something so that my students understand my rationale. Again, with that interest of just making the best possible learning environment for them where they're each getting to grow as they go along. And then this is my organization sheet, especially if I am teaching more than one clinical group in a particular semester. It just helps me keep everything on track so I know what student is doing what each week and can send the appropriate information. Once I've made my assignment for the day, then I put my game plan together. I always have this pre-populated, these sheets. Once I know my student roster for the semester, I put their names in here electronically, and then I just print these and have them in a clipboard that I keep on the unit. This is where I put what room number or what patient they're working with and what nurse. And then this just keeps me on track with what time do I need to be where to give meds as people come up, or if I notice, oh, we can go do a condom catheter on this particular patient. I write this in, and I also have a highlighter, and it just helps me make sure that I'm in the right place at the right time and have a clear game plan with medications, particular skills that need to get done. And then once I have this filled out, then I can see where I'm going to huddle. I always try to huddle with them, by 10:30. So I do a quick huddle to make sure everybody's got their assignment, has a plan for the day, has met their nurse, has gotten a report. And then I do another huddle starting before lunch and going through after lunch, where I get them to verbally present their patient to me. And then I give them feedback on their critical thinking, their prioritization, and I ask them questions like, what's the worst that could happen? What would be your nursing intervention that would indicate that you're seeing some of those changes and potential patient deterioration of hemodynamic status? What are some interventions that you would have planned in case that worst complication occurs? And so that clinical questioning happens every week. That could be uncomfortable for students at first. So that's something else that I am very clear and transparent about. I will be asking you questions and really pushing you to think about the particular situation. You don't have to know the information, but you have to be clear about, okay, if I don't know that, I'm clear on the resource I would use to look it up, and we'll talk about it again in post-conference. So this game plan sheet, I'm a checklist person. When I have 8 to 10 students, especially when I start assigning more than one patient. So when I get up to 3, 4, and 5 patients for some students, especially those that aren't giving meds that week, when I give them multiple patients, this really, really helps me stay organized and on top of, keeping patients safe, making sure we're communicating to the staff, and just make sure that we all remember to get a break and check in as well. The organization is so critical to those first couple of weeks of the semester. So this is just another kind of visual of what does our structure for the day look like. Again, I showed you my game plan sheet, and I do change that depending on the type of clinical that I'm teaching. There are different things that I add. And then kind of our pre-conference morning huddle that we have. I do this around the time that clinical's starting. We still try to make it to the hospital unit kind of welcome, and I try to make sure that my students hear handoff of care. Unless there's something very busy going on the unit or things like that, we might jump right into care, and then try to get report when we can. Again, your higher level learners are going to do really well with being flexible, being dynamic. Your newer learners need that very clear structure, at least for the first 3 or 4 weeks of the semester, if not longer. We spend most of the rest of the morning or whatever the beginning of our shift is doing assessments, med pass, AM care. And then again, right before lunch, I try to start to huddle with them. And when I say they give me a patient presentation, it's 2 minutes or less. And we talk through and I give some feedback and they continue to progress. Everybody has different preferences for this. I send all of my students to lunch at the same time. And then that gives me time to eat lunch, to check their charting from the morning, and to check in with all the staff and make sure there are not any concerns that need to be addressed before we continue through the rest of our shift. There have been other times in a leadership clinical where I have them give handover to each other and they have kind of a staggered lunch. But again, that's specific learners and for specific course objectives. In kind of most clinicals, I find sending everyone to lunch at the same time really helps me have some time and space to kind of prepare myself for the rest of the shift as well. After lunch, we continue on. Again, students that didn't give meds in the morning, I try to make sure they get some concentrated meds and concentrated time with me. We try to get as many skills as possible and other interventions that the patients need for the day. And then I try to do a balance of building their confidence through exposure and task and meds, with making sure that I'm also paying attention to their ability to start seeing patient care beyond just tasks and interventions, and really trying to get them to move towards critically thinking about and clinically questioning what they're doing, what's their rationale, and really trying to make sure that they are having that good systematic approach to care using the nursing process, using the clinical judgment model. The last part of our day, and at our university we have a whole hour for clinical wrap-up. This is never a time where we are lecturing at the students or having some kind of teaching didactic session. The biggest part of this day is always a kind of emotional, mental debrief first. I make sure that every student has time to debrief. Sometimes we do a quick free write reflection. If I have a quieter group that doesn't like to talk as much, we'll do a free write real quick. And then we'll have some kind of think, pair, share, where then they have time to pair up and talk about it, and then some call outs to the larger group. Really that ability to emote, get some of those feelings out, and do some reflection is so critical to making sure that everybody transitions back to life outside the hospital. That mental health and well-being, and really trying to set an expectation that that's how we will begin our clinical post-conference and end it. After everybody has had time, kind of the middle of our post-conference, we do talk about the patient cases in a general way, from a nursing care delivery prioritization perspective. Sometimes I'll get them to do their huddle verbal presentation again if they did a really great one. Or if there were a lot of changes. Let's say that there was a MET call or a cardiac arrest after I huddled with them in the morning, and everything about the patient changed and the plan of care changed for the rest of the day. That's a really great teaching opportunity for the rest of the group to kind of talk through that process. And then on those really busy days where I did not hear anybody's verbal presentation, I will get them to give me their verbal presentation in post-conference, again adhering to that 2 minutes or less. And most of them get it down to about 90 seconds because it's just that concise, what's most important about the patient care for the day and what's their nursing plan. I always like to share what I do for alternative learning experiences as well. And when I say alternative structures and learning experiences, we're still on our home unit that we've been on every week, but let's say I walk in and their staffing is really not great and it's too much of a burden to give a nurse, students to work with on top of a larger patient assignment. So, I make different types of assignments for my students that day where they are contributing interventions in a way that makes sense, but we're still preserving their learning. Other things that I do if there's not quite enough staff or patients, and then sometimes, when the learners are further along, we have a team leader and a charge nurse who's responsible for the rest of their team. So if I have a group of 10 students, I'll have 2 people in the charge nurse role, and then they each have 4 nursing students, so they're responsible for rounding on all 4 of the patients, checking all of the charting, facilitating when learning activities come up. They have to make sure that they're communicating the plan for lunch, they're communicating our meeting location at the end of the day and what the plan is overall. The team leader is really kind of a really great role for you as a clinical instructor too. And you kind of are still supervising the larger group, but you're giving your students an opportunity to be a leader for the day as well. All of the student scope of practice still applies, so they cannot oversee and supervise any nursing care delivery, but they can do rounding, check-ins, provide suggestions to a student, different things like that. Help them turn a patient. Something else is peer-to-peer chart checks. So if we don't have a charge nurse for the day in the student role, I might still ask students to check each other's chart checks and make sure that they hit all of the list of what's expected to be charted for the day. I also have them practice giving handover of care to each other. Now, I might do that on a normal day, but it might be something that we practice a little bit more if we've got to do some alternative learning. If we don't have the same types of, one student to one patient for the day type of situation, that traditional learning model. Something that's been a big hit with my students that totally came out of a really bad day on the unit when we just could not do traditional learning. I created a grand rounds experience where I got a computer on wheels and we saw all 30 patients on the particular unit, and I showed them and kind of role modeled a couple of times how I would navigate through the patient's electronic health record, and then how I would make a plan to go in the patient's room, and then we'd all go and assess the patient, come back out, talk about the plan, and kind of move forward. Very similar to medical rounds, but with a nursing kind of high quality care delivery and patient safety perspective. And after I did 3 or 4 of the patients, then I had each of the students do several of them. It was the best day of clinical I've ever had, and students loved it. So I have started to incorporate that, not out of necessity, but in an intentional and planned way now, just because it was such a big hit. And we still did a tremendous amount of patient care. And by seeing every patient on the unit, we actually got to do a lot more kind of critical thinking, seeing the big picture beyond just your patient assignment. It was actually a really great learning experience. Another great opportunity is I might have 8 of my students in a traditional patient assignment for the day, and then I might assign 2 of my patients to do central line rounds or case management rounds or round with the advanced practice nurse or physician's assistant for a specified time of the morning. And that has also been a really great learning experience, and I try to rotate students through that in an intentional way. I also will again use that if I just cannot make a traditional patient assignment work for the day. Um, Interruption scenarios is something that my colleague Dr. Kathleen Ray created with Dr. Kim Elgin. These are cards that you can hand to a student who maybe is not super engaged or has a lot of downtime, or maybe their patient has went to the operating room and now they don't have a patient assignment, or they've been discharged. And it can be something like, there's a tornado warning. What's the expectation and the emergency response? You're the charge nurse. Teach us all what you're supposed to do about that. So we have a lot of hypothetical scenario cards. There was just a fall in room 1. What's the appropriate actions to take for that unwitnessed fall? You've had a patient who has eloped or disappeared. What's the appropriate process and steps in that particular emergency situation? The interruption scenarios, again, are something that students really enjoy. It's something that it can not just be if there's downtime, but also if you're later in the semester and looking for things to continue to challenge the students. And then assigning students to work with different members of the healthcare team on that particular unit. And again, that's going to vary depending on the type of unit you're on. But for example, following the lactation consultant in an obstetrics rotation can be a phenomenal experience, but it can't just be observation. They need to be engaged and participating in care delivery as much as possible. That might be doing an assessment and creating a care plan that they're going to document and then report out to the rest of the clinical group. So you can't assign them to someone else on the healthcare team and then it end up being all observation. They need to be engaged in the nursing process and clinical judgment model and have some deliverables there for those alternative experiences for it to truly count for direct care hours. Now let's talk about clinical grading as we wrap up. Clinical grading and feedback are a whole separate video that I have, but this is just some of the kind of big things to remember about this. First of all, making sure you schedule adequate time to do grading. It takes longer the first half of the semester, and the first time that I did clinical grading, it took me 8 hours, and that's because I was learning the process, learning the flow, and then trying to give meaningful feedback to each of my students. Now, being more experienced, I spend no more than 2 hours because I have gotten to the point where I try to give as much feedback during the clinical day and in post-conference as possible, so one-on-one and then as a group. And then I spend my time in my clinical grading looking at any worksheets or reflections that they've written up and giving written feedback on the verbal feedback that I gave during the day so that I have narrative documentation of what we did during the clinical day and what that teaching and feedback was. Your feedback is critical. It must be clear. It must have objective data. And it must reinforce something that was feedback or a performance concern or success during the clinical shift. I actually have created a Word document of smart phrases that I use because a lot of times you're giving very common feedback, and the smart phrases just help me then individualize the feedback to the particular student and situation. My probably biggest pearl or piece of wisdom for grading besides your time is do not provide a student with an unsatisfactory rating or does not meet or that type of thing for the day and give no objective narrative examples and written feedback. And if it's lacking in clear expectations on how to improve. If you just give someone a does not meet and then it's blank, there's no guidance, there's no clarity on what it was that they didn't meet and how they can do better the next week, they are going to probably not reach out directly to you, but kind of spiral and come very unprepared the next week for clinical. Instead of them taking objective data and feedback and clear expectations of how to improve, that gives them the time to prepare so that their performance improves for the next week, or they seek out additional support and resources at their particular school before they come back to clinical the next week. So if someone could not appropriately use the unit-specific Dynamap and really struggled with that and required a lot of supervision to do that basic skill, maybe they also didn't ask for help. You want to very clearly and directly provide that information and then provide them maybe they need to watch a video. What is their learning style? Do they need to watch a video? Do they need to go into their lab and practice? Do they need to spend some time before the next clinical practicing with that piece of equipment? Trying to really get down to what the underlying learning need is and addressing that. So never leave your comment section blank if someone is not performing at the expected level. Also, in the first couple weeks of clinical, trust yourself and trust your assessment and instincts. You want to refer students early for a second opinion on their performance and then ask for additional coaching. All schools of nursing are expected to have remediation plans and programs. If you need to write a success plan or a remediation plan for a student, ask your course faculty or your clinical colleagues to help you write that first one. You should never do that alone and struggle through it, because it's a legal document that, it's very high stakes, and you really want to make sure that it's formative, that it's truly giving the student clear expectations with a clear plan that they need to follow and be held accountable to. And so it's really, really critical that you work through those first couple of success plans for struggling students, not in a silo. There are lots of resources at your particular schools of nursing to help you with this particular situation. And then something else to kind of think about that is people don't love giving feedback that is less than rock star status. And then sometimes they're not clear, don't come across as clear about it being something to improve their clinical performance, care delivery, ultimately quality and patient safety, and trying to get the students to see the feedback for what it is, instead of an emotional or defensive response. And so that's another time where it's really taking time to be really clear about what the expectations are. And then thinking about, is there a time when you might need to fail a student for the day? I think that that's so critical, again, to give clear performance feedback. If it is truly a failure in patient safety or performance for the day, it should be given to the student with a clear success plan on how to improve over the remaining days of the clinical days of the semester, because then you're at risk for not having given feedback to the student so that they did have time to be successful in the semester. So they have to be given every opportunity to be successful before they ultimately have a clinical failure. So that failure to fail, some students are going to be unsafe and are not going to be able to progress, but we on our side have to have clearly documented our feedback, clearly documented expectations so they can be successful, and then it's up to the student to follow through on that success plan and those check-ins that they might have with the school, with their course professor, and with their advisor. And then I want to leave you with some recommended references that I use on a regular basis, and there are 2 books that I find to be extremely helpful for new clinical faculty, and then are great resources as you're looking to continue to build your management strategies. So Fast Facts for the Clinical Nursing Instructor is a really great resource to help you get started. And then Marilyn Orman, Teresa Schellenberger, and Kathleen Gaberson's Clinical Teaching Strategies in Nursing is also an excellent resource. Even if you have an older edition, like the 3rd, 4th, or 5th, still a really great resource with lots of guidance on how to implement an evidence-based, inclusive clinical learning environment. So I will leave you with that for today. I hope that it gave you some tips and reminders on how to structure your first couple of days of clinical. And I hope to be able to share more tips and pearls with you on this YouTube channel. Thank you so much.